micrometers, you are unlikely to show any visual field loss. So in other words, when your retinal nerve fiber layer thickness becomes more than 75 micrometers, that's when you start noticing the visual field. And that guides us as to when to do OCTs and when to do visual fields. And so this is what I tend to do. For early disease, where the retinal nerve fiber layer is relatively thick, then I tend to do OCTs in terms of diagnosing the glaucoma. If in advanced disease, particularly when you're monitoring it, I tend to use visual fields. And for those sort of patients in between, I tend to either alternate or, if I can, do both every visit. So that's what I'm doing differently nowadays. I've been giving more and more thoughts into the impacts of our decisions when we're in clinic. What's the impact on our patients? What's the impact of our treatments? And what is the impact on frequent tests and visits? If we bring patients back more and more, this has an impact on the financial sustainability of our care models, as well as inconvenience to patients. And finally, what is our aim? What are we trying to achieve when we manage our patients? And I would argue that what we're actually trying to do is maintain a sighted lifetime, taking into account quality of life. And that's becoming more and more important. I think that second part, the quality of life. This was a paper that was published in 2014 in IOVS for Moorfields. And this influenced my thinking quite a bit because it showed that more than 90% of patients predicted to progress to statutory blindness had a mean deviation of worse than -6 decibels in at least one eye on presentation. In other words, if the patient is going to go blind, most likely they're going to present with quite bad visual fields. And that's also helped to guide in terms of what we're trying to achieve when we manage our patients. So we're trying to improve or maintain quality of life. So if we have two patients here, a young man, for example, or an elderly woman, it's going to be a very different approach that one takes in order to maintain or improve their quality of life. If this patient has a very severe glaucoma, one might need to initiate more severe interventions, whereas an elderly lady who's likely to, for example, to pass away before they go blind, then you need to take into account less aggressive treatments. We're all familiar with this concept of, normal patients do deteriorate with age anyway, and what we're trying to do with glaucoma patients is to decrease the steepness of this deterioration. And that may mean sometimes we need to reduce or cut drops, because that will improve their quality of life. So that's something I'm doing much more often nowadays. I'm taking people off drops rather than just adding on all the time. So every single patient I see, I think, are we over treating this patient? And I think once you bear in mind, their rate of deterioration, and sometimes stopping the drops is the right thing to do if you want to improve their quality of life. Just a few words on high myopes. It's well known now that there are some patients who are particularly high myopes, particularly young male myopes, who have what looks like to be bad glaucoma, but if you follow them up over a long period of time, they don't get any worse. And we think that's probably due to some sort of stretching in the early days, in their sort of teens and 20s, when their myopia is progressing, and that stabilizes once the myopia stabilizes, and therefore treating these patients is not always necessary. One can sometimes observe them to see if they're progressing or not. So again, that's something I'm doing more and more often, and not just jumping in to treat patients. Just a few words on SLT. I know not everyone has access to an SLT machine, but this the LIGHT study, which was just published a few years ago, has certainly influenced my management of patients. This was SLT versus eye drops for first-line treatment. And just some inclusion-exclusion criteria that I've highlighted the main ones there. And they were around about 700 patients were randomized into the two treatment arms. And to cut a long story short, in the interest of time, you will see that the SLT group, there were 78% were medication-free at 3 years, compared to obviously with the drop group at 3%. And interestingly, the trabeculectomies, none were in the SLT group, whereas there were 11 patients in the drop group which needed trabeculectomy. And interestingly, the side effects were very minimal. There was only one patient that had an IOP rise that needed treatment, and there were no IOP spikes more than 10 millimeters of mercury. Should we be using SLT more as first-line treatment for treatment-naive patients? in my estimation, I think the answer is yes, and I'm certainly doing that a lot more. There are some caveats, of course, particularly whether the results can be replicated in Asian populations. There's a China Light study, which is being published as well, which follows the same protocol as the Moorfield study, and that will be relevant for East Asians. No talk on glaucoma is complete without a mention on MIGS, and this is the Horizon study, which was published just this year, which showed that indeed the addition of the hydrous microstent does appear to be safe and reduces intraocular pressure. However, this study also that was published just, I think it was this year as well, which showed that this was a comparison between hydrous and iStent, who are the two big leaders in this field, and it showed that actually the 24-month outcomes, there was no significant difference between the two. So I tend to use both hydrous and iStent, but of course you have to choose your patients carefully. Models of care, this is quite a big topic in itself, but certainly in Singapore, we're now doing more virtual clinics, and we try and divide our patients into those that need to be seen face-to-face by an ophthalmologist, whereas those with less severe disease might be managed by a hospital optometrist, even remotely by a hospital optometrist, and maybe even by community optometrists. So we're now grading our patients in terms of their disease severity, and choosing the model of care that's appropriate to them. And this is really about cost effectiveness. We have to be very careful about how we spend the taxpayers' money in terms of healthcare, and choosing the right model of care that's the most effective for that patient's condition is something we're doing more and more often now. This is just one example of what we're doing. So, for example, for pre-COVID, because COVID was really the impetus for all this, patients would come to the hospital, have their tests, see the doctor at the hospital, and then go home. But now, more and more, we're getting patients to have their investigations in a community setting, which is out of the hospital. The patient then goes home. A doctor will then review the data remotely on their laptop. And then if there's no change in management, which is the majority of patients, the patient is sent an SMS text to inform they're okay. But if there is a change in management, we can do a video consultation with the patient, and or even a face-to-face, and then tell them about the change. So it's a big topic, and you know, in the interest of time, I can't go through in all details, but that's something we're doing a lot now, and probably about 20% of our patients are managed this way now, and we're expecting that will increase to around about 40% in the next year or two. Finally, I'm going to end with just a video of a trabeculectomy, which I will just go through this. So I use a corneal traction suture, superior corneal traction suture. Then what I tend to do is sort of pinch up the conjunctiva and just give a little bit of subconjunctival lignocaine, as you can see there, to create a little bleb. And then I use the Vanna scissors just to cut the conjunctiva away from the limbus. And then I get the Westcott scissors to cut away the tenons. So I do this in 2 steps, really, because I think it's so crucial that you get underneath that tenons layer. And then you sort of dissect back as far as you possibly can and do some diathermy. And then I use a Tooks knife to clear away some of that episcleral tissue. I tend to do this pocket incision. So I use the crescent knife to sort of tunnel forward into the sclera here. And then I make a couple of side cuts to make a rectangular flap. I tend to use pre-placed releasables, one on each side. MMC next. So I'll use this core clamp designed by Professor Penn Core to sort of hold the conjunctiva. And I still use a sponge-soaked MMC. Some people are now injecting MMC into the tenons. I used to do that, but I found that they tend to become a little bit avascular, so I've gone back to using a sponge. So once the MMC is done, we take out the sponges. I put the sponge underneath the flap as well. Take out the sponges, and then I make these sort of corneal slit incisions. These are a little bit thick and deep compared to the ones I normally do. And I tend to put 2 releasables, one on either side, identical on either side. And I tuck them into these little corneal slits that I've made, so you get a little loop there, so that on the slit lamp, if you want to release that suture, you can just pull that suture out and it releases. So this is how I do a releasable. I'll just show you on one side, so sort of partial thickness through the sclera there. You pull it through, You keep the flap flat as it is, so you try not to lift the flap so it stays in the same anatomical position, and 45 degrees through that corner. And I leave it here. I don't tie it at this stage. I do the same on the other side, leave it loose, so I don't tie it. If I'm going to do cataract surgery, I'll then do it there and then from the side port, but in this case, it's not just a trabeculectomy. So I'll make the sclerostomy with a Kelly punch, and I do an iridectomy. So I'm also not doing iridectomies in some patients as well. I find you get a lovely looking bleb if you don't do an iridectomy, but the trouble is sometimes they do get blockage, and I've had to go back and laser them, which is a little bit of a nuisance. So most of the time I do the iridectomy. And then of course you just tie off these releasables and so that they're reasonably tight, and then cut them short. And then I will close up the conjunctiva in the usual way, some purse strings on the two edges there. This is the first one. And then on the second one, I try and tuck the sutures underneath the conjunctiva. And you can see the tenons there, the white tenons is pulled up down to the limbus, which is perfect. Then I usually put 2 or sometimes 3 mattress sutures as well, just to make sure that just to make sure that cornea is tight. Let me just show you that right at the end there. To make sure that limbal wound is tight and there's no leakage, and then I give some subconjunctival dexamethasone at the bottom, and that's it. So in summary, I use guided progression software, specifically Forum from Zeiss if it's available. I use a 10-2 more and more often for patients with visual field loss close to fixation. Remember, I always try and remember the aim for our patients is to improve or maintain quality of life. And that may mean in many cases, taking them off drops or medication, and of course, bearing into mind their age, which will guide how aggressive your treatment is going to be. I sometimes observe high myopes. I don't always treat them because I want to make sure they are progressing. If you have access to SLT, I certainly do that in many cases, particularly if they're naive to treatment. I use MIGS, but only for suitable patients. MIGS is another topic in itself, of course, but suitable patients, not for all patients, of course. And we're also doing using new models of care, specifically virtual clinics, as well as combined working with collaboration models with our optometrists, both in the community and in-house, such that the management of care is appropriate to this condition. Should I start the second talk now? Dr. Richard, should I start the second talk now?
Professor Ahad, now it will be Dr. Malka's talk, and then it will be yours.
Sure. Okay. Thanks.
Dr. Pradeepa, madam, you need to unmute yourself.
Thank you, Professor Hussain, for that comprehensive overview on the current management trends in glaucoma. The next speaker is Dr. Imalka Fonseca. She's a senior consultant ophthalmologist at Durton's Hospital, Colombo, and she's going to talk about normal tension glaucoma. Over to you, Imalka.
Good evening, everyone. Can you hear me, Pradeepa? Can you hear me?
Yes, madam, can hear.
Okay. Good evening, everyone. Let me first thank the Glaucoma Interest Group of the College of Ophthalmologists of Sri Lanka and Novartis for inviting me today. I'll be speaking to you on normal tension glaucoma. It accounts for 30% of newly diagnosed primary open-angle glaucoma. However, it is more common in the East. The Tajimi study showed that 93% of their glaucomas were NTG. The risk factors shown to be related to normal tension glaucoma are age, with a mean age in the 60s. However, 30% is seen below 50 years of age. Sex, females, a higher incidence is seen, probably due to longevity. And race, higher incidence of NTG is seen in Asians, especially East Asians, and those with systemic conditions such as vascular disorders, migraine, vasospastic disorders, and immune-related diseases are known to have a greater incidence of NTG. The best definition I found of normal tension glaucoma was the Moorfield's definition, where I defined NTG as an IOP, a mean IOP of treatment consistently equal or less than 21 millimeters of mercury on diurnal testing, with open drainage angles on gonioscopy, with typical optic disc damage, with typical glaucomatous cupping and neuroretinal rim damage, with visual field defects compatible with the glaucomatous cupping, that a positive disc field correlation, with an absence of any secondary cause for glaucomatous optic nerve damage. Very important to exclude a previous history of raised IOP following trauma, period of steroid administration, and episodes of uveitis. Otherwise, you could easily misdiagnose these cases as normal tension glaucoma. The pathophysiology is largely unknown, at best speculative. Factors involved in the possible etiology of normal tension glaucoma could be categorized under pressure-dependent and pressure-independent. The collaborative normal tension glaucoma study clearly showed that IOP played a role in the development and progression of NTG, and reduction of IOP could benefit patients at risk of progression. The pressure-independent factors are vascular perfusion defects. Higher risk of progression is seen in those with migraine and low blood pressure, and those with defective autoregulatory mechanisms. Also, those with autoimmune involvement and low cerebrospinal fluid pressure are also shown to have a higher risk. The natural history of normal tension glaucoma, as shown by the collaborative normal tension glaucoma study, showed that the level of pressure influences the course of NTG. The rate of visual field loss was decreased in patients whose IOP was lowered 30% or more, and the rate of progression without treatment was highly variable, slow enough that half of the patients showed no progression over a period of 5 years. A faster rate of progression was seen to occur in women, those with migraine, and those with disc hemorrhages. And some patients experience a greater benefit from lowering of IOP than others with NTG. The results of the collaborative normal tension glaucoma study showed that NTG is slowly or non-progressive in approximately 50% of patients. Thus, those patients destined to be non-progressive derive no benefit from treatment. Hence, treatment should be individualized according to the stage of the disease at time of diagnosis, higher the chance of starting treatment if the glaucoma is more than early or moderate. Rate of progression, age of the patient, and IOP, which is in the higher teens, which will show a higher chance of being in the progressive category. This is a simple algorithm for us to, when we are managing a normal tension glaucoma. When you're faced with a patient where you suspect NTG, you have to first establish that it is NTG by doing a diurnal phasing. Then you carry out your functional and structural test, that is OCT and the visual field. Then if it is confirmed as normal tension glaucoma with positive visual field effects or positive structural changes, then you take it as confirmed normal tension glaucoma and you follow these patients up, look for progression. Unless they are advanced or in stage or more towards even moderate glaucoma, if it's more towards advanced, then you should start treatment. Otherwise, you look for progression without starting treatment. With serial optic disc examinations, serial visual fields, at least 3 per year, and your structural tests, and also ask for subjective deterioration. In those who show no field defects or structural changes, they should be followed up as NTG suspects and not confirmed NTG patients. And again, you look for changes over time with serial optic disc examinations, serial visual field tests, and your structural tests. So when do we start treatment? If progression is detected, either objective or subjective, we need to reduce the IOP from baseline by at least 30%. And also we need to exclude treatable risk factors as the cause for progression, such as nocturnal hypertension, vasospasms. And in advanced disease where MD is greater than 15 decibels, we need, or where the fixation is threatened or split, immediate IOP lowering is prudent. And in these patients, we will require at least a 40% reduction of IOP. In patients with risk of progression, such as females with a family history, migraine, and those with disc hemorrhages, if we are not starting treatment, we need to monitor them closely. If there's no way of monitoring them closely, it's better to start them on treatment. Just stuck there. So can I just check whether the YB is not moving? Just excuse me, I can't get the next slide. It's not coming up. Next slide. There it started. Go back. Sorry about it. So how should we set target IOP in our normal tension glaucoma patients? How much is low enough? So at least a 30% reduction of IOP from baseline to retard progression is required. Advanced disease may require greater reduction of IOP as much as 40%, and older patients with no risk factors and moderate disease, a 20% reduction may be adequate. So what should be the choice of treatment? Prostaglandin analogues should be the best choice, is the best choice currently available because of factors known to all of us: better IOP lowering, higher safety profile, flatter diurnal IOP fluctuations, good compliance due to once daily dosing with no deleterious effects on ocular perfusion. Beta blockers should be best avoided because of the possibility of affecting ocular perfusion, especially in elderly patients. If you have to give, it's best to give it pretty early. I give it around 5 p.m. if I have to give a BD dose, otherwise I stick to only morning. So prostaglandins may have to be combined with glaucoma medications in patients who show progression on monotherapy and in those whom you choose to treat medically first in advanced NTG. Adjuvant therapy. Neuroprotection, alpha agonists, some positive results have been shown in animals and human studies. The regular cardiovascular exercises such as walking, jogging, swimming would decrease intraocular pressure and also increase ocular perfusion. So you could, I always advise my patients to do regular cardiovascular exercises to never hurt anybody. The reduction of weight if obese would reduce the chance of sleep apnea as a cause of progression of your glaucoma. To quit smoking if they're smokers, which will help prevent vasospasms and prevent nocturnal dipping of systemic blood pressure. So you may have to liaise with the physician who's looking after them regarding that. Meditation as an adjuvant therapy. Professor Tanu Dada from the All India Institute of Medicine carried out a beautiful study, and the results showed that meditation decreases intraocular pressure in primary open-angle glaucoma. It also decreases diurnal fluctuations of IOP, and it has a direct impact on the trabecular meshwork gene expression with upregulation of neuroprotective genes and downregulation of pro-inflammatory genes. So you could ask your patients to do meditation, again, which will not harm them at all. There's a lot of hype about neuroprotection with vitamin B3. So vitamin B3, also called niacin or nicotinamide, is it neuroprotective? Many studies have shown that NAD declines. Many studies have shown that it is showing neuroprotective effect, and NAD declines in the retina in an age-dependent manner, rendering the retinal ganglion cells susceptible to neurodegeneration. And hence, preventing NAD depletion with administration of nicotinamide and NAD precursor could prevent glaucoma damage. Hence, by elevating NAD levels through nicotinamide administration, we can improve visual function in existing glaucoma patients. These findings provide hope for a treatment that could preserve nerve cells and help those that have already been damaged to function better. A long-term study will be underway, a 4-year clinical trial by Morpheus with UCL, I think starting in August, to see how effective this would be. Surgical intervention, when do we intervene surgically? In advanced normal tension glaucoma patients, if target IOP cannot be achieved with maximum tolerated therapy, then end-stage normal tension glaucoma, only surgery will enable a good 24-hour control. And those who progress despite achieving very low target IOPs, less than 10, also will require single-digit IOPs to prevent progression. Hence, surgery will be a must. So what is the choice of surgery in these patients? It should be trabeculectomy with mitomycin C. This should be the first choice. IOP should be consistently kept at 10 millimeters or below in advanced and end-stage glaucoma if you want to prevent progression. In conclusion, patients with NTG should be aggressively treated, and when there is established progression, a 40% reduction will be required. 30% will not be enough in advanced and end-stage disease. There is strong evidence that single-digit IOP slows progression in NTG. Hence, trabeculectomy with mitomycin C is even effective in patients who show progression, even with preoperative IOPs of 12 millimeters of mercury. You can stop the progression or minimize progression with the trabeculectomy. Thank you.
Thank you, Imalka, for that very comprehensive coverage of normal tension glaucoma, which we consider as a gray area where a lot of us have doubts regarding the diagnosis and management. Thank you again. I have to remind the audience to send in their questions addressed to the relevant speakers. Now I have the pleasure of inviting Professor Rahat Hussain again to give his second talk. He's going to talk to us on comparison of clinical effects of topical prostaglandin analogues.
Thank you very much once again. Let me share my screen. Yes, so I'll be talking about the clinical effects of topical prostaglandin analogues, PGAs, a comparison between the different ones available. So I have to report I have received an honorarium from Novartis Alcom, which manufactures Travatan, which I'll be talking about over the next 10 minutes. So PGAs are synthetic drug compounds that mimic the body's naturally occurring prostaglandin F2A, F2 alpha, and they're agonists. And it's worth remembering that they're actually pro-drugs. In other words, they only become active once they become hydrolyzed when they get in contact with the cornea. So you'll be familiar with some of these names, and these are generic names here on the left, and the brand names in the middle column here. They'll be different in different countries, and here are the manufacturers. Just use this one. Okay. So in general, as Dr. Fonseca was saying, that the PGAs have replaced beta blockers as the first choice of treatment in most healthcare systems. Here's the Asia Pacific Glaucoma Congress guidelines, which show that essentially the PGAs are popular as first-line agents. They don't quite say that it should be, but they do note that it's usually given. And the reason for that are quite obvious, actually. They're the most effective IOP-lowering agents. They have a lack of systemic side effects that you can get with timolol, and it's just once a day. And we know that the least frequently you have to instill drops, the more likely the patient is to adhere to treatment. So what I'm going to be talking about is a comparison between the different ones, because it's always difficult to know which one should I choose. There's a number out there, and we need to decide which one do we think is the best. And I'm looking at it in terms of the efficacy, the local side effect, because as I mentioned, systemic side effects are negligible, as well as the cost. But I'm not going to be talking about cost for this talk, because of course that will differ depending on which country you're in. And I don't know what the situation is in Sri Lanka. So I'll talk about efficacy and the local side effects in terms of helping me decide which drop to use. So let's look at efficacy. So this was one meta-analysis, one of the first meta-analyses that were done in 2005. And you can see here that bimatoprost and travoprost were the two most efficacious, although there's not much in it between the different drops, to be fair, certainly the PGAs at least. But interestingly, if you notice here, the difference between the peak and the trough in travoprost was only 2 millimeters of mercury, whereas, for example, bimatoprost, which was 5 millimeters, and that tends to suggest that bimatoprost is going to give you a less even profile. In other words, the diurnal variation is likely to be better with travoprost, as this shows here. There was another meta-analysis done in 2007, and again it showed that travoprost and bimatoprost may have greater efficacy in lowering IOP for patients with these conditions. So it does appear that bimatoprost and travoprost do seem to be the most efficacious. What about tafloprost? At the time of these studies, tafloprost wasn't around. Well, this was a study which looked at comparing travoprost to tafloprost, and it looked at over a 24-hour period. And you can see here the squares are the travoprost, the triangles are the tafloprost, and you can see that at all time points, the travoprost had lower pressure, although the margins are quite small, of course. This was a randomized double-masked crossover design trial, so it's a well-designed trial. In terms of the side effects, they were pretty similar between the two groups, and the only one that was of significance was redness in the eyes, which was apparent in actually both groups, but worse in the tafloprost group. So the conclusion in terms of efficacy is that travoprost and bimatoprost are the most efficacious of the PGAs, but there's not much in between them. And if you look at the diurnal profile, it does appear that travoprost seems to have a better profile than bimatoprost. Well, let's look at the side effects, the local side effects. And for this, I look at two big commonly seen PGA side effects. And this is the PGA-associated periorbitopathy syndrome, or PAPS, which anyone who's run glaucoma clinics will be familiar with it, even if you didn't know what it was called, as well as the ocular surface disease issues that are present with all drops, and prostaglandin analogues are no exception. So let's look at these two sort of local side effects to see which drop has the better profile in terms of that. Well, here's what PAPS is. So there's about 10 clinical features. You get this thing, dews, the deepening of the upper eyelid sulcus. You can see it very clearly here. Flattening of the lower eye bags, ptosis. This orbital fat atrophy and mild enophthalmos is a nuisance when it comes to checking pressure. You can see in this patient here, you can imagine how difficult it will be to check the pressure on her, because you have to sort of lift up that lid, and you can't help pressing on the lid, as well as the appearance, the sort of cosmetic appearance that it causes. You get this sort of tight orbit, which makes surgery particularly very difficult to do sometimes. So any glaucoma surgeon will tell you that, you know, PAPS is a problem, and we're all noticing it now. You know, these patients have been on drops for 10 years. They tend to be reversible. So if you stop the drops, the PAPS does tend to get better over a period of months, in my experience. And so, you know, it's not all doom and gloom, but you know, when you do see patients like this, it's not nice. And so there have been several studies, just one, comparing the different types of PGAs in terms of the PAPS development. And you can see here that bimatoprost by far has the greatest proportion of severe PAP. And that's been reported across different studies, that bimatoprost is probably the worst drop that in terms of causing PAPS. And I think that's no longer particularly controversial, although you do get it, of course, in the other PGAs as well. And I think that, for me, has really impacted its usefulness. Now, it works well. So bimatoprost is a good drop in terms of it lowering the pressure, no question about it. But it's that high prevalence of severe PAPS, which I think has really limited its usefulness because of its effect on quality of life, as well as the simple things of ease of measuring pressure and the surgical problems it has as well. What about ocular surface disease? Well, ocular surface disease and the association with benzalkonium chloride is well known, okay? And this was an audit that was done in Australia, examining the impact of benzalkonium chloride-free anti-glaucoma medications on patients with symptoms of ocular surface disease. And basically, they found that there was a reduction in the use of lubricants if you use BAK-free preparations, and improved patient comfort. And so this leads to improved adherence and quality of life. Again, this is the whole thing about quality of life, which is very much the zeitgeist in terms of glaucoma treatment at the moment. And in 2010, and a BAK-free travoprost was introduced into the market. And instead of using BAK, they used something called polyquad. And so polyquad is an antimicrobial polycationic preservative, which, to be honest, I'm not entirely sure what this means, but anyway, it has a unique molecular and chemical properties that differentiate from BAK. And here's, for those of you who are interested, this is the chemical structure. And it has antimicrobial properties, but does not contain hydrophobic domains, and it does not act as a detergent. Okay, so these, as opposed to BAK. So it is different. But does it work as well? Does BAK-free travoprost work as well as normal BAK-preserved travoprost? Well, this was a study which looked at this, and they compared it to as a prospective multi-center study conducted at multiple sites across the USA, Europe, Latin America, and Asia Pacific. And it was designed to demonstrate non-inferiority. And you can see here, in summary, that actually between the two agents, BAK-free as well as BAK-preserved travatan, it worked equally well in both, and this was based on diurnal IOPs, non-inferior at all time points. And here's just another way of showing that. The mechanisms of action of travoprost BAK-free is by increasing the outflow of aqueous humor through the trabecular meshwork, as well as the uvea scleral pathways. And it starts to work about 2 hours after administration, with a maximum effect after 12 hours, which is why it tends to be given at night, because it's thought that the highest IOP spike is in the morning. So there are several reasons to consider travoprost BAK-free solution in the management of your glaucoma patients. They get a sustained 30% reduction on average for the full day, that diurnal variation, which we think is important. And it's been shown that it has better efficacy in a couple of meta-analyses compared to both tafloprost as well as latanoprost. But bimatoprost may have slightly better efficacy, but unfortunately with bimatoprost you have this problem with the PAP, which can really limit its usefulness. There's an established safety profile, and of course, it's worth remembering it's BAK free, and that has a beneficial effect for the ocular surface, which translates to better efficacy, better adherence to the medication, and better quality of life for our patients. So that's why Travoprost BAK free is a good consideration if you want to lower the eye pressure. Thank you very much.
Thank you, Professor Hussain. I'm going to introduce the final speaker of today's program. Dr. Mudita Kulatunga is a senior consultant ophthalmologist attached to National Eye Hospital, Colombo, and she's going to talk on audit of glaucoma, follow-up patients in your clinic. Over to you, Mudita.
Thank you, Pradeepa. I would like to thank the organizers for inviting me to give this speech today at this forum. The topic given to me is how to conduct a glaucoma audit in your clinic practice. So I'm going to outline my speech today with what is audit and research, and what do we do by doing an audit, what do we expect by doing an audit, what is audit cycle, and steps of a good audit analysis, and how to check the accuracy of your audit, and how to publish your audit and the conclusion, and some examples. So what is audit? A quality improvement process that seeks to improve the patient care and outcome through systematic review of the care against the explicit criteria. That is, you set up you compare your care with a known guideline given by known organizations. That's the audit. But what is a research? Research is a tool to assess what is the best practice where there is uncertainty. Now here there's uncertainty and you want to improve your knowledge in that area, advance our knowledge in that uncertainty. So that's the difference between the audit and a research.
Madam, sorry to interrupt. Your slides are not being shared yet.
Sorry.
Madam, do you need any help?
Hold on, I have got this into the thing earlier. Can you see?
Not yet, madam. Jadis, can you share it from your end?
Sorry about this. I thought I have got this into the. Hold on, I'll get the open the presentation again. Can you see?
Yes, madam. Now can see. You can continue.
Sorry about it. So now I'm somewhere here. It's not moving up or down from this place. Are you doing a remote control here? Because I can't move the slides. Can you see my slides now?
Yes, madam.
Okay. Right. So the important thing about audit is it measures whether the already known best practice is actually occurring in your clinic. And most of the time, once you do the audit, you need to reassess whether the said shortcomings were addressed. After about a certain period, you have to reassess and see whether the shortcomings that you identified in your audit had been addressed. That's called the re-auditing. So it is basically to improve the quality of care that you give to the patient and increase the efficiency and reducing the mistakes that you do in your clinical setting. So then this assures the quality of your care for your glaucoma patients. And also it improves the quality given to reduce the risk and harm to the patient. So this is like, so you identify a problem. So how do you sort of set about doing audit in your glaucoma patients? You identify a problem and set a standard, and then you have a way of collecting data. If you like, you can do a pilot testing, but then once you collect the data, you analyze and then find out what has happened, and then you plan a re-audit after a certain period. So identify a topic and select standard and measure the current. So here you are measuring your current performance. What am I doing to my patient? Like, so how am I managing my patients? And you are comparing it with the standard given by a well-known organizations. We have given standard by the College of Eye Surgeons in Sri Lanka as well. So this will compare the performance of your performance and analyze this data critically and make improvements and re-audit. So that's called the audit cycle. So there are examples of audit that you have, the people have been doing. And then you can, if you are doing your audit, you can compare with guidelines by either NICE guidelines, especially in our country, we have been like the college has given guidelines, American Academy, the Royal College. So, other than that, you also can do the audit on staff availability, adequacy of the training of the staff, equipment, and the physical environment of your clinic, and also the time that you give for the glaucoma patients. And also, in addition, you can check the history and examination written by the doctors in the notes, and then investigations, whether the investigations are done at the correct time, whether the patient care and the intervention is done at the correct time for the correct patient, especially whether the progression is detected in your clinic, because very often, it's very busy clinics we have, so we won't be able to see all the glaucoma patients who come. The consultant or the chief of the clinic cannot see all the cases. So sometimes you miss the progression, the cases that were detected quite late. So this can actually, if you do regular audits, this can be stopped actually, because this is done by a team. So you can advise your team that this is where we have gone wrong, kind of thing. So at the end of the thing, what we are aiming is to give better care for the patient and improving quality of life and life expectancy also, because blindness anyway causes early death. So therefore, it's very important that you detect improve the quality of life for the patient. So how do you select a sample? Selecting a sample size is like for your audit, you can keep the confidence, the level to 95% confidence interval. And also the error, the most commonly kept the margin of error is 5%. But in my study, I kept 10%. And then you select the number of cases, I mean, like 1,000 patients or whatever. And then you calculate your sample size using an online resource. So you can do a prospective one or a retrospective audit. So the advantage of the retrospective audit, which is done most commonly a retrospective audits we do, is that it is the results are not influenced by the people behaving differently, because at that point the people in the clinic, the doctors and the team, they don't know that we are doing audit, so that's the normal behavior. But the disadvantage is if you have any missing data which you want to find out, which are not entered in the clinic files, you will not be able to analyze. Whereas the prospective one, you can analyze whatever the facts that you want. But there'll be a bit of a bias because the team knows that you're going to do audit because it's a prospective audit, and so the behavior will be different. And also it takes a long time for the prospective audits to finish. So you have to have a questionnaire and ensure the language is understandable to the patients and the team, and also have a person who is to collect the data, a person who understands the disease and how to enter the data. So if there are more than one data collector, there should be uniformity among them. So you have to sort of advise them like that. So if you like, you can do a pilot study, but I believe you can collect data and analyze it. So this is the action plan. Now here the audit, this is an example of audit I did together with my team, and we audited 1,984 patients, eyes of 984 patients from 2010 to 2020. This is the audit setting, the National Eye Hospital, Colombo, and my clinic. And this is the study team. So this team includes all the nurses, minor staff, doctors, registrars, and everyone. So it's very important that you get everyone into this kind of activity, because otherwise it's very difficult to implement anything. If you want to change, it's difficult to implement unless you get the entire team into your whatever the activity you're doing. So this is a Google form. This is Dr. Dileepa Disakaruna, who is with me next to my left hand, who actually helped me with this data collection and entry of the facts. Now here the survey, we have a Google form. We sort of formulated a Google form which indicates what factors we want to find out. So the age group, then the gender, then we sort of entered where the patient came from, and also the type of glaucoma that we are treating the patient for, and how the patient's glaucoma was controlled, whether it is medical treatment, surgical treatment, added. If it is medical treatment, whether it is monotherapy or multitherapy, and how many patients were lost for follow-up, and the types of glaucoma. What are the types of glaucoma we found? So I was so surprised. We found wealth of information with this 10-year study. So we analyzed this data using SSP26 version, the package of that is the statistical package for social sciences 26 version, and entered this in these charts. Results came in charts like this. So here we can analyze the accuracy of the data. The cumulative index should come to 100 if the data are fully accurate. So the accuracy of the data can be analyzed with your once you enter and use this package. So here the cumulative index and large number. Now the audit covers the large number of people, resulting where the descriptive analysis with a very narrow confidence. So this, in my study, our study, we were able to apply this for national data. So this is the first time we have sort of statistically analyzed the types of glaucoma that in Sri Lanka. So here the age group, gender, location, where the patient came from, whether the patient presented to the clinic on their own or patient requested, whether the patient requested glaucoma screening or patient came for something else and found to have glaucoma. And also the types of glaucoma. Types of glaucoma is also very important. So here, what did we find? We found a lot of very interesting things about the glaucoma trend in Sri Lanka. So we found 64.5% of people were having primary open angle glaucoma. Second group was the very high percentage of secondary glaucomas, which is related to globe ruptures, industrial injuries and globe ruptures, especially the young males were involved in this. 20%, 19.8% of the glaucomas are due to secondary glaucomas. Then comes the chronic narrow angle, then ocular hypertension and subacute angle closures. Primary angle closures about 9%. So how many patients now? A lot of patients, about 84.5% were treated with medical management alone. And we have started from treatment in majority, but 1 year later, all those who were followed without treatment, about 60% were started on treatment. So the age groups, in this study, we found 71, the age group of 61 to 70 is the highest in Sri Lanka. Now, if you see this chart, so our strategy of screening 40 above is very well depicted here. So 41 to 50, 51 to 60, 61 to 70 is the highest group, and 71 to 8. So this group is the people that we advise to screen, which is a good, like depiction of what we have been doing is correct. So the gender distribution fairly equal. So we found people from entire island and how they presented to the clinic. If you see this now, 50% of the people didn't know they were having glaucoma when they came to the clinic. So it's so important that anyone coming to the OPD or your clinic for anything else, please, you have to look for glaucoma. And 49.4% came for glaucoma screening. So this is also fairly good statistics for our country, because normally in countries like ours, about 80% of people didn't know. Normally they don't know they have glaucoma, but in developed countries, the rate is about 50%. So we have got about 50.6%. So the type of glaucoma, 64.5% were having primary open angle glaucoma, and secondary glaucoma is about 19.8. So if you see the medical therapy, majority was started on monotherapy initial, but about 68% went to multitherapy within 5 years. So this shows that we are adding up the second drug, very frequent, like very likely that because the drugs are given from the government free of charge and the drugs were available at that time. And so we have, without checking with the requirement for the second drug, very likely we have added the second drug. Because sometimes patients, the compliance we must not check, or the installation techniques, whether the patient has forgotten to put the drop for 3-4 days, and a long-term adherence. We must check all this before adding up the second drug, and also the progression. So very likely we have added up the second drug without thinking. When you think about adding the second drug or over treatment, the compliance reduces by 60% when you add the second drug. So you have to think about that also. In this audit, it was highlighted. So the patients who required surgery was 8.29%, but 46% of them controlled only on the surgery alone. So majority underwent trabeculectomy, some underwent tubes and tubes later. So, but the important thing is surgery, early surgery is very important in this audit. What came, the highlighted was the surgery early intervention is very required in this stage. And there was 9.6% loss for follow-up. So now this audit showed us a lot of statistics which were really required for this country. So I'm sorry if the internet connection is unstable. So very likely now regarding this audit that we have to say now, what we have found out is, because we are doing away with these clinic files. The clinic files are removed when the glaucoma patients don't come for over 1 year. This habit is also we should do away with, because now the annual checkup for these glaucoma patients is really required. Therefore, we have to have a way of electronically or otherwise maintaining the regular records. So this is the guideline that we have given, the glaucoma interest group given recently. We have been giving guidelines from time to time, updating this. The college have been doing it. And these are the examples of audits done elsewhere on similar setting. Now, if you see the audits, the glaucoma audits, certain audits are done on facing, and certain audit also. And it's so very interesting that we can we have to do facing, restart the facing, because we actually had been doing the facing, but which was stopped during the COVID time. Now, reassessment of the quality in the final stage of the audit is often referred to as closing the loop. The audit, you close the loop, means re-evaluate after approximately a certain time, and then the quality of the practice, and then you have to implement the shortcomings, and then redo the audit. So that becomes the audit cycle. Now, finally, you need to know that there's a wealth of evidence to say that the standards are available for ophthalmologists, and how to measure your care in relation to standard of care to improve the quality of care for the glaucoma patients. And all the ophthalmologists have a duty to, do audits and pre-audits, so that you maintain the quality of care for your glaucoma patients, because this is a lifelong disease. Thank you very much.
Thank you, Madam, for an informative speech on how an audit has to be taken for glaucoma patients. So with that, now let me move. Now we are going to actually move into the Q&A session. So let me invite Dr. Hiranya Abeysekara, Consultant Pediatric Ophthalmologist, Joint Secretary, College of Ophthalmology, Sri Lanka, to take over the screen. Over to you, sir.
Thank you, Dr. Manisha. So I think today's session is very interactive. So there are a few questions on the chat box, and Professor Hussain has already answered few. So I will read out the questions and answers for the benefit of everybody. So one question was, who are the patients that are selected for MIGS? The question was answered by Professor Hussain. POG patients on 1 or 2 drops mainly, not too severe. Sir, do you want to add anything? Have you got anything else to say about this?
Not really. I mean, the point is, if the glaucoma is very advanced, then I would just go straight for a, phaco trab or trab. I think if it's too mild disease, let's say ocular hypertension, I might do a MIGS, but I might just do the cataract surgery. You see, so it's that sort of middle ground that I do the MIGS. Yeah.
Thank you, sir. So another question: is it advisable to switch from bimatoprost to travoprost if the patient is getting orbitopathy with the former? The answer is yes, may be worth it, although I would probably try a non-PGA. Then another question to Professor Hussain. Do you believe in non-penetrating glaucoma surgical techniques, example vesicanalostomy? Answer was, I have to say I don't have much faith in non-penetrating surgery. The reason is that it's been around for a long time. If it's really was better, then we should have seen the data by now. I know some surgeons say it's wonderful. Another question, Professor Hussain, what is the best anti-glaucoma drop to start in very young patient with P or AG or juvenile open-angle glaucoma at early stage, considering the side effects of prostaglandin analogues? Answer given was, I would still start with a prostaglandin analog such as Travatan. So I think those questions are answered. Another question to Professor Hussain: what investigations would be the best to assess progression in end-stage glaucoma when retinal nerve fiber layer thickness hits the floor? Answer is, I would use HVF 10-2 if necessary, which was answered by Professor Hussain himself. So another question to Dr. Imalka Fonseca. Madam, are you online? There are a couple of questions to you. One question is, dear madam, when should we consider neuroimaging in normal tension glaucoma?
Can you hear me, Hiranya?
Yes, madam, very clear. Yeah.
Okay, so actually, because of me being given 15 minutes, I couldn't cover that part. So neuroimaging should be considered, not in every patient with NTG, but those who show very rapid progression, like 1 decibel per year, or those where the visual field is observed in the vertical meridian. Then dyschromatopsia on Ishihara color plates, that's another indication. And where your disc is not sort of the visual field and the disc that you see, they don't match properly, where this visual field correlation is not there. Those are the things. And also I would say very poor visual field, which is not in keeping with the state of the glaucoma in the patient. So those are the indications where we should do neuroimaging.
Thank you, madam. Another question for you, madam. When carrying out diurnal facing, how many hours should we carry it out?
Yeah, now that is a question I would answer differently. Now, when I was in the government sector, I would get the patient in, keep the patient as a ward patient and do it every 2 hours, blood pressure as well as the IOP. But now I'm completely in the private sector, so things have changed. You have to, I do it about 3-4 times. That is, get them down at different times during their different visits and then determine whether it is really normal tension or high tension glaucoma. There's no other way that you can get down patients every 2 hours or every 4 hours on a single day in the private sector. Does that answer your question?
Yes, madam. I think that's the answer the trainees wanted. Thank you very much, madam, for your answers. I think that's all the questions we have got. Are there any questions or other questions trainees want to direct to the speakers? Monisha, shall we conclude?
Yes, if there's no other questions, then you can proceed with the vote of thanks and then I can do the closing.
Yeah. Okay, thank you. So it's a formality that I have to thank everybody who involved in the success of this program. So it was a wonderful program and a good Q&A session. So first, I would like to thank our guest speakers on behalf of the College of Ophthalmologists of Sri Lanka. First and foremost, I would like to show my gratitude to Professor Rahat Hussain from Singapore National Eye Center. Thank you very much, sir, for your excellent presentations and staying with us for the Q&A session as well. Thank you so much for your time. And a special thank to our own local experts, Dr. Mudra Kulatunga, consultant ophthalmologist, and Dr. Imalka Fonseca, consultant ophthalmologist. Thank you, madam, for your elegant presentations, which helped our trainees particularly to learn facts about glaucoma management and research. Thank you very much. And there are 2 names that I have to mention as the main pillars of success of this workshop. Mr. Chanaka Tisavirasinga, franchise head, and Dr. Monisha Richard, who is the medical advisor of ophthalmology, immunology, and dermatology of Ebawa Company Private Limited, who kindly sponsored and coordinated this program to the last minute. Thank you very much for your efforts and time and the funds you have spent for the benefit of our membership. Thank you very much. And I cannot forget the efforts of our College of Office staff, particularly Ms. Samanmali and Mr. Mahesh, who were involved in extensive work done to bring about this workshop. Thank you very much. And last but not least, I would like to thank everybody who participated today's workshop. Thank you very much. Your participation is highly encouraging for us to organize more workshops of this nature. Thank you very much.
Thank you very much, sir, for the vote of thanks. On behalf of A. Bahrain Company, Market Expansion Services for Novartis, I would like to thank our guest speaker, Professor Rahat Hussain, for joining us today virtually from Singapore. Thank you very much, sir. And my sincere thanks to our eminent speakers, Dr. Imalka Fonseca and Dr. Mujita Kulathimpa, for an informative session. Thank you, madams. My heartiest thanks to Dr. Pradeepa Sirivardhan and Dr. Hiranya Abhisekara for allowing us to partner with the college for this webinar. Thank you, madam. Thank you, sir. My thanks to Savanmari and Mahesh for the coordination and the support provided on behalf of the college. And also, I would like to thank Jellies and his crew for the technical support provided today, even with all the difficulties they faced today. Last but not least, I thank my dear colleagues of Novartis for extending their support to make this event a success. And last, my thanks to all the doctors who participated today and for all your active listening. Thank you very much. So with that note, we have come to the end of session. Thank you, everyone. Good night and stay safe. Thank you.
Thanks. Bye.
Bye.